All right. Hey, everybody. Thanks, Donnie, for having me back to Orthosono. Good to be back in Vegas without masks. These are my disclosures. My name is John Knab. I'm an anesthesia-based interventional pain specialist, practicing since 1997. We've been using PRP and stem cells since 2015. We do a lot of spine. We see a lot of hips, knees, shoulders, ankles. And I'm from the good Wilmington, North Carolina, not Delaware, where 80% of people are doctors, 10% are in the film industry, and the other 10% clean up after hurricanes. So 3 years ago, I had never even heard of shockwave or EMTT, and now they are both an integral part of our practice, something I use every day, and I could not function without. So I'm going to explain why I like these therapies and give you some backup with basic science and level 1 evidence, and then see if you guys have any questions. So here are the learning objectives. So why are you listening to me talk about something that sounds like voodoo? 2 words, big gaps. Okay, what's the first question people ask when they come in your office and you start talking to them about stem cells? Is it covered by insurance, right? So gap number 1, cost. Some people cannot afford orthobiologics. They don't want surgery, they don't want steroids, so they're in a pickle. Gap 2 is downtime, especially for in-season athletes or runners. They ain't got time for downtime. Gap 3 is efficacy. Cell therapy isn't always as effective as the patient was thinking it would be. So what do? Shockwave and EMTT. These therapies fill in the gaps. Simple. Okay, what the hell is shockwave? How many people are currently using shockwave in their day-to-day practice? Never heard of shockwave? Okay. Shockwaves are not voodoo. They were first used in lithotripsy back in the 1980s to break up kidney stones. We used to dunk patients into these huge bathtubs where under anesthesia, giant shockwave machines would break up their kidney stones into smaller stones over here so you could pee them out. And this involved like anesthetizing people, dunking them in these bathtubs. The interesting thing is you could break up these stones without damaging the kidneys. So I found this on the internet. This is the exact moment when a young Swiss orthopedist with kidney stones first asked, can I use these shock waves to break up the pain for shoulder calcifications? And sure enough, it worked, and the field of shockwave therapy was born. Focused shockwave devices today are basically just miniaturized versions of the original lithotripsy devices. So in shockwave therapy, the mechanical energy of sound waves are converted into biologic effects within the body. This is called mechanotransduction. It can be either direct, where sound waves break up calcifications, or indirect, where sound waves act as biologic triggers for biochemical processes within the human body. There are 2 broad categories, radial and focused, and we'll get into that. So focused shockwave is, the Mac Daddy, right? It's stronger, really effective for well-localized and deep areas of pathology. And radial shockwaves are like the baby brother. It's cute, it's noisy, it does not penetrate very deeply, but it's a much more efficient tool for covering larger areas like the quads, hamstrings, trunk, that type of thing. This is not a Theragun or a Hyperice. The radial shockwave is much, much different. So EFD stands for energy flux density, which is how we measure dose in shockwave. On the left, you can see that the highest EFD over here is found at a point far away from the focus device. And here on the right, you can see that the highest EFD is found immediately adjacent to the radial shockwave device. There are 3 types of focus shockwave generators and only 1 type of radial shockwave generator. The device uses electricity to generate a miniature sonic boom. And this process creates a focal point of pressure at a fixed point right up here beyond the handpiece membrane. On the bottom right is a radial pressure wave device. This is a pneumatic gun with an oscillating bullet in a barrel hitting the applicator tip over here, which vibrates. Treatment intensity is either adjusted on the machine itself or at the handpiece. We measure energy in millijoules per millimeter squared. Just like with a magnifying glass, out in the sun, the maximum energy is not right next to the device here, but it's here at a fixed point beyond the device at and near the focal point of these sound waves, which kind of come together in a conical shape. We adjust the treatment depth by using gel standoffs. Tall standoff down here is when you're treating superficial tissues. Nose standoff is what we use when we're treating the hip. Deeper structures you can get down to 12.5 centimeters. So it's important that we measure the depth using ultrasound of our targets before we start shockwave. So this is a radial device. Maximum treatment depth with this guy is 3.5 centimeters. And depth is adjusted by putting on different applicator tips. And we measure EFD and bar. These are the applicator tips. So when I give these talks, a lot of people call me or email me afterwards saying, you know, I think I want to add this into my practice. Which one do you think I should use? And I think you know the question. They're totally different tools, and you need both. I've actually drilled through my index finger trying something like this about 20 years ago. So how does it work? We don't know. All right, thank you. Have a nice day. The exact mechanism of action of shockwave is unknown. However, the biological responses of tissue to shockwave therapy are known, and these include a lot of the same things that we see happening with orthobiologics, you know, increasing nitric oxide, increasing synthesis of collagen types 1 and 2, tenocyte proliferation, substance P modulation, downregulation of pro-inflammatory cytokines, upregulation of anti-inflammatory cytokines, and some of the other same things that we see when we are using PRP and stem cells. So, you know, when I was trying to first explain this to my partner, trying to get him to purchase these devices, I explained it to him in that way. And I think the light bulb went off for him, and he said, go ahead and get them. So I explained shockwave in simple terms to my patients, saying that it's non-invasive orthobiologics. Does it work? Well, let's look at some studies and clinical examples. This is level 1 evidence supporting shockwave for a number of common musculoskeletal conditions that we treat. This is a level 1 study in 245 patients with chronic recalcitrant plantar fasciitis, 2 groups. Active treatment group receiving 4 weekly sessions of radial shockwave, and the placebo group receiving a sham treatment. At 12-week follow-up, there was a significant difference in first-step VAS and overall success rate in the shockwave group versus the placebo group. And the differences were further pronounced at 12 months. The same group did a follow-up study in 2015 using 3 weekly sessions of focus shockwave, also showing superiority of shockwave compared to placebo in plantar fasciitis. Another level 1 study, 40 professional athletes with chronic proximal hamstring tendinopathy, 2 groups, focused shockwave receiving shockwave once a week for 4 weeks versus traditional conservative therapy. And at 3 months, there was a statistically significant difference in the shockwave group versus TCT in terms of VAS, inertial phase rating scale, and percentage of patients reporting 50% improvement or greater in pain. And inertial is kind of how poorly you feel after overexerting yourself, you know, the next day. 80% of shockwave group were able to return to full sport at 3 months with no re-injury during the entire 12-month observation period, compared to no patients in the TCT group who were able to return to full sport at 3 months. This is a systematic review and a meta-analysis from 2018 by Moya, showing that there are grade A or B, which means good or fair, recommendations for shockwave for most of the MSK disorders that we treat. Another study by Moya showing resolution of painful calcific supraspinatus calcifications, where shockwave was used as monotherapy. Some of these results were achieved with a single session of focused shockwave, up to 3 sessions total. Okay, BMLs, bone marrow lesions, hot topic in orthobiologics right now, right? Intraosseous, that's the sexy, hot, all the cool kids are doing it. Did you know you can also treat painful BMLs with shockwave? This is a group of 86 patients with painful BMLs of the medial compartment of the knee. 2 groups, 55 received focus shockwave once a week for, once every 3 weeks for 9 weeks, so a total of 3 sessions, and 31 patients received no treatment. And at 3 months, there were statistically significant differences in VAS, WOMAC, and a decrease in size of BMLs on MRI in the shockwave group compared to the non-treatment group. This is a 14-year-old girl, non-union after a motor vehicle collision, tibial fracture consolidation not achieved at 12 months. So she got 4 weekly radial shockwave treatments, and she is pain-free with walking and consolidation of the tibial fracture at 18 months. So in addition to treating bone, muscle, and tendon pathology, shockwave is also very effective for nerve pathology. It may work by modulating CGRP. The dose for nerve disorders is typically a lot less, about 1/3 of what we apply for bone marrow lesions and osteonecrosis. Dose matters. So I'll briefly go over some of the contraindications and practical considerations. There are very few contraindications for shockwave therapy. These are the guidelines from the ISMST. A couple of other pearls. I treated a upper cervical spine pain that I was having with focus shockwave, high intensity. I can take it, I'm pretty tough. I ended up having about a month and a half of tinnitus after I did that. Would not recommend that. It did resolve. I also had a near vasovagal episode when I was using radial shockwave, high EFD, for myofascial trigger points in my vastus lateralis. Again, I'm pretty tough. I can take pain. It was a Saturday. I had been drinking the night before heavily, and I started feeling a little nauseated. And then I started feeling a little sweaty. And then I checked my pulse, and it was about 32. So I stopped, lied down, and averted a near catastrophe. So if your patient is looking green around the gills as you were doing shockwave, stop. They're probably about to pass out. This is a cash paid service. You have to decide how you want to integrate it into your practice. Per price per session, depends on a number of factors. We have our basic price is $300. We can go up to $600 depending on if we're treating bilaterally or multiple sites. You should use a standard consent form, and patients should always sign an ABN since it is not a covered procedure for most insurances. Treatment typically once a week. Sometimes we speed it up for an in-season athlete who's really trying to get to a goal very quickly. And we also use a lot of shockwave day of and following cell therapy. This is probably the most important slide in the whole talk. This is my team who does all of our shockwave, EMTT, and laser. Megan in the center is a retired or semi-retired PT who is an amazing asset, especially with shockwave. You've got to have an implementation plan before you start down this path, unless you're just starting out and have plenty of time, because this takes time. You also need to check with your local and regional regulatory agencies to know whether or not non-physicians can administer shockwave and EMTT. Okay, crash course on EMTT. How many people are using it? Familiar with it? Okay, that's what I thought. We were one of the first clinics in the US to get a machine in July 2021. We've delivered over 10 million impulses in the past year, and our average treatment consisting of 6,000 impulses, that's about 1,500 treatment sessions so far. It was approved by the FDA in January of 2021. It's been in Europe for over 5 years. No reports of any serious side effects. That's been our experience as well. EMTT is a healing accelerator. It uses an electromagnetic field of approximately 0.8 Tesla. MRI is about 1.5 Tesla, just for comparison. And these electromagnetic impulses transmit to a depth of 18 to 20 centimeters. Tissue is exposed to rapidly oscillating electromagnetic pulses. Pulsed EMF, or PEMF, is EMTT's fat, slow, boring old uncle. This guy in red. EMTT in blue is rapidly oscillating, about 40% stronger than PEMF wave. It reduces spasms. It increases blood flow. It re-educates muscles and nerves. And there are also some pretty cool effects of EMTT at the cell membrane level, which we exploit in our practice. You can use it on most body parts, very few contraindications. Here's me treating both my knees at the same time, since there's an electromagnetic field on both sides of the wand. Didn't know that at first. It's really easy to use. When I tell my staff 886, they know I mean power level 8 hertz, and 6,000 impulses. We have had no serious side effects or complications in all of our patients since starting using it. We don't get any post-treatment flare-ups that sometimes can occur with shockwave. Like our robotic laser, it's an AMF yo-yo therapy, meaning you set it and leave the room, so it's very efficient. Typical session is about 10 to 20 minutes, and same contraindications you would have if you were sending someone for an MRI. I did erase a Home Depot gift card, and we have our patients put their belongings in the small safe outside the treatment room. This is an article from 2017. This is why I got it. 88 patients with nonspecific low back pain randomly got 6 weeks of either PT and analgesic drugs or a combination of PT and 8 sessions of EMTT. Patients receiving both EMTT and physical therapy and OTCs did better with VAS and ODI at 6 and 12 weeks compared to the PT group alone. So this terrible MRI is an actual patient of mine, my old accountant. He's a 69-year-old guy who presented with a 6-month history of progressively worsening low back pain, axial, non-radicular from L1 to L5, referred to me by neurosurgery. They did not want to touch him. He's miserable, not getting better with steroids, like maybe 40% better for a week after injections. So I gave him a free treatment and he gets immediately better, 60% better, one treatment. But his severe pain comes back about 2 weeks later. So he asks, can I continue with this instead of going on to PRP, which was our next step? So we did 4 weeks, 8 sessions total, 6 weeks. He was really not much better. And so we began talking about PRP and radio frequency, spinal stimulator, etc. But 1 week after that, while I was at a meeting presenting on shockwave and EMTT, he texted me about 45 minutes after I gave my talk, saying, Johnny, I'm about 80–90% better here. I'd like to do some more EMTT if that's okay with you. So then we did that. 4 more sessions, and this was 11 months ago. This is his MRI at about 6 months after his last EMTT, and we see persistent motor changes, so that's a bummer, but complete resolution of his HMP at L1-2 and improvement of the stenosis that was previously here from severe to mild. Functionally, he is playing golf 2 to 3 times a week, and his pain level has been reduced by at least 75%, maybe 90% by his account. So this is my MRI showing a far lateral disc bulge on the left at L3-4 impinging upon the exiting L3 nerve root. I developed an L3 sensory radiculopathy in the fall of 2021 after a kiteboarding injury, and there's a far lateral disc bulge at L3-4. I had symptoms for about 6 weeks, not getting any better. I followed the same protocol that we've been talking about, placed the wand at my left L3-4 disc space, just to the left of the midline. During treatment, I could feel a non-painful pulsation in my back, but not in my leg. I had 2 sessions, and I've been pain-free and numbness-free for 9 months. I'm back to full sport, including kiteboarding, snowboarding, pretty much anything I want to do. Final case is a combination of shockwave and EMTT. 18-year-old female, friend of my daughter, came to me in January 2022 with a history of right foot 5th metatarsal avulsion fracture. Jones fracture, you can see here, happened in 2017. And after that, she had a long recovery course, multiple attempts at non-weight bearing, boot, casting, eventual healing over the course of 2 years. And she re-fractured the same area, being clumsy, April 2021. And again, gets into this cycle of non-healing. Ortho guys telling her she's got to have surgery, ORIF. She's freaking out. She's 18. She just wants to surf and hang out at the beach with her friends. So this is her x-ray, fracture at the 5th metatarsal base, no periosteal reaction. It's been 9 to 10 months. We treated her 3 weekly sessions of focus shockwave, 3,000 shocks per session, pretty low EFD, only 0.15 millijoules per millimeter squared, 4 hertz. And we also gave her simultaneous EMTT 886 at those 3 treatment sessions. I was a little concerned she might not get better, because we could only get up to moderate strength on the focused, and there were some gaps in between the sessions due to her traveling back and forth to Brazil. Here she is getting EMTT through her Uggs, which she liked because it was cold. And this is her x-ray at 16 weeks after her first treatment, showing complete healing of the non-union. She has improved range of motion at 3rd, 4th, and 5th digits. And she's happy. You know, she's got mild pain when she's very active on her foot, but otherwise doing well. I told her we could keep going if she wanted to, but she said she was all good. So shockwave and EMTT are comprehensive therapies. They're also dynamic therapies. When I treat someone with plantar fasciitis, I don't just treat the pain generator like this guy's doing. I treat everything all at once. I smack all those moles back down into the holes all at once. I treat all the way up the kinetic chain, even all the way up to the hip sometimes, and the results have been a game changer for us. This is my posse at Park City last year. Can't go this year. 3 of these maniacs are my patients. We're busy, aging athletes. We don't have time for 6 weeks of physical therapy. We know better than to get steroid injections, and we also know we're nowhere near ready for surgery. Sometimes they're not even ready for PRP, me included. So shockwave and EMTT help me to keep myself and my posse going. These tools are non-invasive orthobiologic devices. They're supported by basic science, level 1 evidence, and hundreds of case series with more data being published regularly. Thank you for your attention. Contact me, text me. Don't call me, I'll never pick up, but I will respond to your text or your emails. This is all the smart person stuff. Enjoy. Have a great day.